Good afternoon. As a land-grant institution, we would first like to acknowledge the Gabrielino Tongva peoples as the traditional land caretakers of Tovangar, that is the Los Angeles Basin and South Channel Islands, where UCLA sits. My name is Inez Ponce, and I am the director of the UCLA Center for Health Policy Research and professor and chair in the Department of Health Policy and Management at the UCLA Fielding School of Public Health. Thank you for joining us today at our webinar, Reducing Barriers for Breastfeeding in California. Nearly 200,000 women in California are living with breast cancer. In California alone, more than 4,200 women die of breast cancer every year. That's more than 11 women every day who die from the disease. Research studies have shown that breastfeeding contributes to the prevention of breast cancer in birthing women. And while breastfeeding is promoted for many reasons benefiting maternal and child health, only 38% of women are aware of this link between breastfeeding and decreasing their risk of breast cancer. There are a number of structural issues that prevent people from accessing breastfeeding education, support, and care. And there are further barriers that challenge people to initiate or continue breastfeeding, particularly for various racial and ethnic groups. So one strategy for reducing racial and ethnic inequities in breast cancer rates centers on improving breastfeeding rates, particularly among Asian, Black, and Native Hawaiian and Pacific Islander populations. Through funding from the California Breast Cancer Research Program, we conducted a study to understand attitudes toward breastfeeding, perceived barriers to breastfeeding, and resources that are available to help people effectively breastfeed, and develop a series of recommendations and policy interventions to increase awareness and support. Findings from the study are available in the report titled Reducing Barriers to Breastfeeding in Disadvantaged Communities. Today, my colleague, Dr. AJ Scheitler, one of the study's lead authors, will share research findings, including 3 policy notes on some of the challenges faced by women who enter or return to the workforce, and recommendations for improving workplace accommodations for breastfeeding mothers. I would like to thank the researchers involved in this study, including Dr. Scheitler, Dr. Riti Shimkata, Dr. Sue Babby, and Dr. May Sudinaraset. And I personally want to thank the participants who shared their insights for this study. If you're interested in today's slides, you can request them from our communications department at healthpolicy@ucla.edu. And the slide there, shows the actual links and also recorded seminars. I would also like to let you know about our next event on Wednesday, February 7th. 1 week from today, we will host a book talk and conversation with Dr. Colleen Grogan, a renowned expert on the U.S. healthcare system and the author of Grow and Hide, The History of America's Healthcare State. Dr. Grogan will discuss her book and will also be joined by UCLA Luskin School of Public Affairs professor and UCLA Center for Health Policy Research Senior Fellow, Dr. Mark Peterson. It's going to be a really great conversation, so I hope you join us. We'll post a link to more information in the chat. Now it's my pleasure to introduce my colleague, Dr. AJ Scheitler.
Hi, good afternoon, everybody, and thanks for joining us today. As my colleague, Dr. Ponce mentioned, this study was funded by the California Breast Cancer Research Program, and their interest in this space is because there is a link between women who breastfeed and their reduction in their risk for developing breast cancer. And so they asked us to look at communities that both have disproportionate rates of breast cancer, as well as, traditionally speaking, are less likely to breastfeed and more likely to encounter barriers. And so that was the focus of our study today. They are interested in promoting breastfeeding and reducing those barriers so that more women are able to successfully have a plan to breastfeed and carry out that plan for as long as they'd like to be able to breastfeed. Currently, recommendations are up to 1 to 2 years recommended breastfeeding and the feeding of breast milk, even if it's expressed. So 9 in 10 mothers have ever breastfed, but only 6 in 10 tend to make it past the 6-month mark. There's 4 in 10 that breastfeed at 12 months. And since these aren't quite getting up to the recommendations, there is a desire to help women who want to be able to meet these goals, to be able to break down the challenges that currently face them. And so we sought to look at what are those challenges that women are experiencing? And we looked across the literature, we looked across legislation about what women are supposed to be entitled to when they choose to breastfeed. We engaged a community advisory board to help us look at the study design, interpret the findings, and help us make the recommendations that we have for policy and program changes to help improve breastfeeding, and also to aid us in recruitment of the people who participated in this study. And for that, we wanted to talk to providers who work with women in these key populations of Asian, Black, and Native Hawaiian and Pacific Islander communities. We wanted to talk to community groups that support maternal and child health and work in the space of breastfeeding, and then mothers themselves who had given birth within the past year to really understand and hear straight from them what their experiences have been. So our main themes. Breastfeeding is not yet normalized. It is improving, but it still has a ways to go. There are societal issues that affect this. There are cultural norms, particularly among these 3 groups of interest that we looked at. And also, it still isn't quite as robust among providers talking to these women and promoting the breastfeeding and helping them to anticipate any challenges so that they can be successful on their journey. There is a disconnect between what is in law and what is in practice. As I mentioned, we looked across the US and federally at what the rights of women are. They differ a little bit from state to state in terms of how much family leave you have, in terms of who's impacted by, company sizes differ and their impact of whether or not they have to adhere to some of the laws that are on the books. But we also just found a breakdown in employers sometimes not knowing what necessarily the current law is. Employers may be knowing but not complying, and that ultimately some employees didn't even know their rights or don't feel they're in a place where they can fight for their rights. So these were big barriers that we uncovered in our study and got recommendations for trying to address. There are also issues in these 3 groups to really find resources that are culturally appropriate, that are truly speak to the women who were in our study and speak to them and their unique situations of the cultural community that they operate in and the support system that they may or may not have because of that. Also, the connection to resources is impacted by a lack of insurance coverage and sometimes a lack, again, of knowledge of what the insurance covers, what it should cover, and again, what women are entitled to and what they should be able to ask for. So, breastfeeding plans. There's a lot of influences that go into a woman's decision. Some women, if it's difficult at first, they may give up. Some women make different goals. Their goal may only be the time that they're going to have off of work. It may be in adherence with some of the recommendations from organizations like the American Association of Pediatrics or American Academy, pardon me, of Pediatrics, or the World Health Organization. There are also major influences that are very close to them. Did their provider talk to them about it? Are there social influences in the spheres and the communities that they operate in? And what kind of support or detraction are they getting from their own families? So there's a lot of inputs that go into a woman's decision, both to try to initiate breastfeeding and for the duration of time that she may set as a goal for herself. One of the biggest impacts about the duration of breastfeeding, even for those women who wanted to and successfully initiated, were requirements for going back to work and the challenges of converting from breastfeeding exclusively to pumping and the different technical logistics that are involved in being able to successfully do that. And then still the family impact of, was still present in the decision about how long a woman wanted to breastfeed. So we heard a lot about the benefits of doulas and lactation consultants. We heard from women who had access to one and or the other of these services, and they spoke very highly of what it did for both their decision to decide to want to breastfeed, but then also what happened if they encountered challenges and there was someone there to help them kind of get through it. And so having access to a doula and or lactation consultant, which do not have some overlapping roles, but are not the same, but both of them played a significant role in influencing a woman's decision to try to breastfeed and in their ability to be successful at it. A few women in our study literally went from their own experience of giving birth and wanting to breastfeed to wanting to become a doula or a lactation professional because of the value that they saw in those roles and wanting to provide those services to other women. So we asked all of the providers in our study, as well as the mothers, is what experiences are you seeing that women are having if they are able to physically breastfeed in carrying through with their goals? And one of the first things they said was that from the beginning, education and knowledge. There isn't necessarily widespread understanding about the benefits of breastfeeding or the technical aspects of it, particularly for first-time moms. They may not really know what to expect. There's a lack of knowledge about, again, the rights of women, both for employment and insurance. What are they entitled to with respect to breastfeeding? Some insurance companies cover pumps. Some insurance companies cover lactation services. Employers of certain sizes have to have a certain accommodations, but not everybody is aware of what's available to them or what to do if, for example, their employer is not adhering with the laws that are on the books. There is also a lack of representation in educational materials and promotional campaigns, and so some women may not really see themselves in that messaging and may not engage with that in a way that promotes breastfeeding for them. There are also barriers that come from community and culture, and this differed quite a bit among the women that we talked to. One of the biggest influences, though, was their immediate family unit and whether or not there was support for and examples of breastfeeding within the people who were closest to them. But beyond that, some women experienced language barriers when it came to accessing services. Some women, if they have a certain immigration status, may not feel comfortable trying to avail themselves of some services that are out there. And again, making sure there's culturally appropriate support is still an issue that stops some women from seeking the care and help that they should be getting. There's also costs. There are certain people who would say, oh, well, breastfeeding is cheaper than formula, so isn't it, it's a better thing financially. But there are expenses associated with breastfeeding supplies, particularly if you're going to pump and be back in a work setting. There's also expenses associated with support services if you run into challenges and want some outside help to get you over those challenges. There's also the financial impact of unpaid maternity leave for women who want to spend more time than is currently allocated under paid leave to be at home with their babies and continue their breastfeeding journey. And that leads to financial concerns, the need to return to work because you have bills, we all have budgets that we have to be able to meet, and so that was a significant impact on a woman being able to carry out her goals, as well as the need to return to work because the company wasn't going to allow for additional unpaid leave if that was something that the woman was in a position to try to take advantage of. For those women who did go back to work, workplace accommodation presented another barrier. We heard unfortunate stories about completely inadequate facilities. There should be a clean, private room for women to be able to, do their pumping in. And there's far too many stories that people hear about the bathroom stall being the only thing that you get. And pumping while working is also a challenge when you have, in certain jobs, when scheduling these kinds of things becomes a barrier for some women to do. And not being able to pump on a consistent and regular basis has an impact on milk supply. And so ultimately, this can really derail a woman's ability to continue with her goals if she wants to. In our study, as I mentioned, we spoke directly to women. We conducted interviews with each of them one-on-one, and our report has a lot of direct quotes from these people. And I think it's incredibly important to listen and hear from their voices directly. Because one of the things one of the examples that one of them gave in the study, I think is such an important thing for people to hear. There was a provider who was participating in her role as a doctor, but relayed her own experience about when she had a child, when she came back to the practice, a place where you might suspect that, breastfeeding and maternal and child health was, significantly promoted and would be well accommodated, that she was told that, yes, we have a great room for you. You absolutely can take all the time that you need to, do your pumping, but you have to see the same number of patients in a day that all of the other physicians have to see. And so there is the law, there is technically adhering to the law, and then there is sort of the intent of the law and what it's supposed to accomplish, that maybe there is room for improvement here. I'm not sharing tons of quotes within this presentation today in the interest of time, but I invite you all to look at the policy notes and look at our report, because we do share a lot of, straight from the women's mouths what their experiences are, and I think it's very important for everyone to hear. So at the end of listening to the challenges that these women faced, and that the providers knew that their patients and their the women that they were trying to support were facing, we asked them what their recommendations were in an ideal world. What would make things better for them? So education. As I mentioned, there is definitely the need for improved and expanded prenatal education. The women who were in our study were geographically diverse across California, and where they gave birth made a significant difference in the type of either classes or materials that they had access to, and whether or not those classes or even their own providers covered the topic of lactation and nursing plans prior to anyone giving birth. So there was a real opportunity here for us to try to improve across the board what education is, make it less dependent on where you go to deliver, and more just, if you're a pregnant woman, this is information that you're going to have access to as you go on through your journey. The lack of education was often associated with an inclination not to even try to start breastfeeding. And the advocates and the support groups that participated in our study said that they felt like once women got educated about it, they were far more likely to be inclined to try to breastfeed. Again, this is another quote straight from a woman who talked about the fact that education would make up for the lack of support from the community in terms of wanting to try to initiate breastfeeding. Many women in our study talked about the fact that they, either didn't want to breast or didn't think they were going to breastfeed because they didn't see their mom or aunts or anyone else in their family ever doing it. And this was across all three of our groups, Asian, Black, and NHPI women, all talked about the influence of whether or not the generations above you or the women around you participated, really heavily influenced whether or not they would. And so if this doesn't exist for some women, having that educational component to come in and try to help make up for that could be a very important resource that could really improve rates in many communities. Again, that family impact was really important. And so as we're looking at education, we maybe shouldn't only focus on the women, because if they don't have the support system around them after they leave, the hospital or the lactation specialist office, they may not continue if they don't have the support at home. And so understanding that the family impact is significant for women and incorporating that into education and public campaigns could really make a difference in both their choice to breastfeed and the duration for how long they ultimately do it. Hospital support services, again, I mentioned it varied, the experiences of the women, including a few of the women in our study who had had multiple children and had not given birth at the same hospital for each of their children, talked about, well, this time, this is the way it happened. But I remember, a few years ago when I was in this place, it was a very different environment and a very different experience. And so, promoting this more broadly across all, and making sure that all hospitals are equipped with information and classes for these women could be significantly helpful. Lactation consultants also, some women, reported having one when they were in the hospital, but when they left the hospital, they didn't have access to that person anymore, and that made a significant difference. And so their recommendation was not to limit the ability to have that support from a lactation specialist once they left the hospital. Also, the timing of the information that is given was noted by many women to be very important. We had several first-time moms in our study, and they talked they talked about how, even if though they wanted to breastfeed, they wanted to know about that before they gave birth, and they wanted to be prepared, and they wanted to know what to expect. And so they thought the timing of when they got that information or when they first talked to a lactation consultant would be very helpful if it was sort of earlier on in the process and not necessarily like some women reported not talking to lactation consultants until they had given birth. So there's an opportunity there to maybe, have more access for those lactation consultants starting earlier and going longer. That would be really beneficial. The ability to rent or borrow a hospital pump. There's a lot of diversity in the pumps that are out there. And so having a really high quality one made a lot of difference for some women in our study. And then also just staff training, not just the lactation consultant, but all of the people that a woman is going to interact with during her time in the hospital might be really helpful, and making sure that staff have culturally appropriate training and understanding to be able to work with different populations that have slightly different needs. Insurance coverage was a big one. Again, I mentioned the lactation consultants. Most women got to see one in the hospital, but only one woman in our study reported that their insurance covered them after they left the hospital to be able to continue to see a lactation consultant. And she specifically talked about how big of a difference it made to be able to have access to that service. And so coverage is not universal for the doulas, for the lactation consultants. What kind of pump and the quality of the pump you might be able to get, and other support services. Again, it's not ubiquitous depending on insurance, so improving coverage for each of those areas would be a great help to a lot of women. There was one lactation consultant that also talked about the need to diversify that that workforce in California. She specifically was a Black woman, and when she had her birthing experience, she felt like this was a space she wanted to move into, and so she studied and became a lactation consultant. And she worked for 5 years before she met another lactation consultant. She went to a conference in Sacramento, a statewide conference, and she met one other Black lactation consultant, and they both talked about the need to try to recruit more diversity into the field, and to just recruit and improve the size of the workforce for this very important service. Work support. For some, there's employers were supportive, but not proactive. There were some women who, thought, if I'm able to work at home, that would be more accommodating, right? I'll have more control over the situation, but reported that it really didn't necessarily make things that much better. That wasn't the solution they thought it would be, and thought that still there needs to be a focus on the workplace and making sure that the laws not only are there, but are being enforced for all women without any repercussions. The workplace impact, as I mentioned, had a significant impact on, a woman's successful breastfeeding journey. Paid leave was first and foremost the most important thing. California does have one of the best paid leave laws in the country, but it is still well below what most public polling and what the women in our survey said was really desirable in terms of coverage, because there are women who will give up a job because they feel this is important enough, and if they can't keep that job and take the time that they want, that's their only remedy, because this is the most important thing to them. And it feels like there could be space for more accommodation to help women to be able to take this time and be able to provide not only nursing, but the other very important baby bonding things that happen in the first year or two of a child's life. There are also employers who may not follow the law regarding leave or workplace accommodations, and there's a lack of knowledge for women about what their remedies are if they don't feel like their workplace is adhering with the laws that they should be. And so part of education campaigns could also include making sure that women not only know their rights, but they know what they can do if their rights aren't being afforded to them. That leads us into public campaigns. Campaigns were not widespread among the people that we saw in our study. They said mostly they just saw some information at the hospital, and that was kind of the only place they remembered reporting. They reported remembering seeing any, campaigns that encouraged breastfeeding. And said even among those materials and the places that they did see, there was really a need for more diverse representation, not only in racial ethnic groups, but also in body types. They felt that messaging should normalize breastfeeding, and again, not just be targeted toward the mom, but also among the community that the mom is going to be doing this in, to make sure that it is that other people aren't going to throw up barriers because it's not normalized for them. It needs to be culturally relevant. It should involve the members of the community that are, the focus of that campaign. And it needs to be sensitive and avoid shaming of any women who are unfortunately physically unable to breastfeed, even if that's something that they would have desired to do. So we wanted to look at policy and program changes that could achieve some of the recommendations that we heard. And we definitely think that there should be an enforcement of the employer responsibilities under the law, which is space and time to pump, adequate family leave, and space or accommodation for milk storage. That is an often afterthought for a lot of employers, but a very important thing for moms who are successful at being able to pump. Increase the diversity of the workforce, particularly among lactation consultants and doulas. Perhaps if they wanted to provide some financial support for lactation training to increase this workforce within the state of California, that might really help to make them more widely available to women. Normalized breastfeeding, unfortunately, there's not a policy that we can change to bring that about. But if that is sort of the the thoughts that we all have going into this, and that we spread the message about the importance of breastfeeding and the value of breastfeeding and how normal and appropriate it is, that will benefit everybody. And also include increasing peer-to-peer opportunities for moms. Again, because some of the materials and some of the workforce aren't necessarily as culturally representative as they could be, peer-to-peer opportunities can really fill in that space. And so some of the organizations that we worked with in this study are maternal groups that operate, target one of these racial and ethnic communities, and being able to put their community members together was a significant help to those who had got to participate in those opportunities, to talk to other people who looked like them and may have experienced some of the same challenges that they're now going through. They said it really helped to prepare them and get them through some of their own barriers, and be able to, achieve their goal for much longer than they may have anticipated being able to do that. We think that there should be improved insurance coverage for pumps and services, improved paid leave. Again, I know I'm recognizing that California is one of the leaders in this area, but we can still do better. Enforce the current policies on public as well as workplace breastfeeding practices, provide culturally competent training for providers, and support doula certification with training that includes lactation education, because at the moment, again, whether or not a doula got involved in that side of thing differed depending on the individual person. It's not something that's necessarily standard, but could become an improved practice. Awareness campaigns. We asked the women, what would speak to them? What did they think would motivate women in their community better? They thought that the delivery, social media was still very a place that a lot of women went for information, but they thought that even within that space, healthcare professionals were really the people that were best poised to give that information in a way that it would be heard and believed. Again, the education for women, whether it comes from the hospital, whether it comes from outside support groups, but more women need lactation as part of their journey as they're preparing to give birth. And they said we should really focus on, helping women know what to expect, what to advocate for in workplaces if necessary, and really give them knowledge of their rights, both in the workplace and with their insurance companies. Again, be careful not to shame moms who may not be able to breastfeed, but support all of those, support all of the women who want to at least try and put out a nursing plan. There needs to be representation, again, both in race and ethnicity, but also in the different body types. Messaging should go beyond moms to the whole family and the support network. That's really makes a difference when it's in place. And messaging and resources should be in language and culturally appropriate for whichever groups we're trying to reach. So the next steps. We did the full study, unfortunately found quite a number of barriers that women face, but CBCRP as the funder wanted us to identify 3 priority issues, and those were family leave policies, workplace accommodation, and access to lactation specialists. So we met with some legislative staff and agency staff in Sacramento, and the messaging that we took to them is that we should make sure that family leave policies are aligned more with the recommendations that are being put out there for breastfeeding practices and duration. Whether you want to go with the American Academy of Pediatrics or the WHO, because they are different right now, but getting closer to what those goals are in terms of paid family leave would be very helpful to most women. Also improve awareness among workplace owners, managers, and employees about family leave rights, and make sure that women are fully aware of what they're entitled to and what they can do if there's pushback from their employer on that front. We heard from every woman and every provider in our study that this was probably the #1 issue that could make the most difference, was giving time that was paid so that women didn't have to choose between going back to work and giving their baby the care that they wanted to be able to do. Workplace accommodation for those women, when they choose to go back to work, they should still be able to continue their nursing journeys through appropriate accommodation, both of the physical space and the time and the consideration of the ability to take what they need within the workplace to achieve their goals. This is, I think, a particular challenge when you have people in the workplace who don't understand the importance of breastfeeding, who don't understand the technical logistics of it, so that, they think, oh, she's, that woman's just slacking again. Oh, she's taking more time. She's not really, does she really need to be doing this much? And so again, there's that opportunity to normalize breastfeeding so that more people understand that, yes, what a woman does when she goes back to work is vitally important to the health of the child and her health, and that if there's an understanding of how that all is supposed to operate, there will be hopefully less pushback on women who go back to work and need to have this accommodation made. And then finally, the access to lactation specialists. It can start with making sure that there's an adequate workforce out there, both in the hospital and available through outside organizations, and that insurance covers those services so that women can avail themselves of it. And if there are opportunities to bolster the workforce, it would be really great if we could also increase the diversity within the workforce and make sure that all of the workforce has cultural competency in their training so that they can work all over within California's wonderfully diverse population. So that we took those messages to Sacramento and I put them out there for you, and I am happy to answer any questions. I do have some other members of our fabulous study team online with me, and we are happy to take any questions or comments that you may have on this very important and timely issue.
Thank you so much for that great presentation. Hello, everyone. My name is Tiffany Lopes, and I'm the Director of Communications at the UCLA Center for Health Policy Research. I'll be going through the audience questions, so if you do have a question, please use the Q&A function in Zoom to ask it. So the first question is there a financial impact or benefit of accommodation policies? Like, would this bring more women back to work?
Who would that finances be directed at? I'm not aware of anything, so I'm not even certain. I'm not certain what the question is intended to mean. Are there incentives to the women or to the workplace? If you give a little clarity, I would try to answer that question.
Yeah, the next Q&A answered that about
Okay.
about the the ROI, the return on investment. That the argument is that these benefits will accrue to
I see.
to the workplace, to the employers.
Yeah. The follow-up was, could it help employers see a benefit of having the women return to work?
Got it. Now I understand your question. Our study didn't ask that specifically, and we did not interview employers. In this case, we were interviewing the people on the employee side. In this case, they all felt like it was going to be a big benefit to them. And I would think that positive attitude would have a benefit, but we did not specifically look at that in this study.
Knowing that lower income women face more difficulties, what role should Medi-Cal and Covered California play? Should these programs be changed?
So, so one of the things that we found in our study, it just so happened that several of the women and one of the organizations that participated were specifically with the WIC program. The WIC program, all of the women in particular, the mothers in our study who were in the program, raved about the excellent materials that they were given beforehand, the classes that they utilized during the time that they were pregnant prior to delivery, that very explicitly talked about breastfeeding and making a plan if they wanted to. And that they were all connected to doulas, and that the doulas also talked with them about their nursing plans and intentions. And so it almost seemed like the women in that program had better access to services that our studies showed would be beneficial to all women than those who maybe had traditional employer-based insurance coverage. And so I would almost like to see WIC held up as more of a model for all other coverage plans and programs to sort of aspire to, just given the reaction of those women in our study and how great they felt their experience was, how prepared they felt they were to breastfeed, and how they had access to the resources that they felt they needed when they encountered any challenges.
Thank you. What steps can we take now to improve insurance coverage for IBCLCs who are not dual credentialed as prescribers? And IBCLC, for folks who don't know, are International Board Certified Lactation Consultants.
So there are different avenues toward credentialing to become a lactation professional. And there are differences in what is covered by insurance. And that's something that the state legislature could take on. And, obviously insurance companies could take it on for themselves and decide what they want to cover. Or we could put a policy into place in law that says that certain certain credentials qualify for coverage on insurance plans. And so that is a potential policy lever that could be advocated for and done through the legislative process in Sacramento.
Were any questions asked about?
Sorry, I think Dr. Ponce was also going to respond.
Okay. I was just saying, when AJ and I went to Sacramento to meet with legislators, legislative aides, that was, I think, the the lactation workforce expansion, accreditation, payment reform was of great interest, among the legislators.
Were any questions asked about daycare or care providers when returning to work?
So we did not ask any questions about that. We did have one person talk about the concern of their of a care provider who was not the parent being involved and not necessarily adhering to. So it was a concern for at least one of the people in our study, but it was not something that we heard as a widespread issue. I have since we've started talking to people about this study, heard some anecdotal stories related about that being an issue for other women, but it was not something that was brought up by the women who participated in our study.
What can be done to reverse the lack of understanding and the connection between breastfeeding and breast cancer?
So, because this study was funded by CBCRP and that was an important interest of theirs, we asked that explicitly of all of the people in our study did they know about the health benefits to the mom, and then explicitly, did they know about the connection to reducing their breast cancer risk? Most of them did not. It was never mentioned to them. One or two of them said, oh, yes, I think maybe somebody mentioned that, but couldn't remember what it was. Mentioned that someone said there's a benefit, but they didn't know exactly what the benefit was. They did not remember that the link was to a reduction in your breast cancer risk. And when we asked about messaging for public campaigns, we asked whether or not that would be a compelling argument that might influence a woman's desire either to breastfeed or to continue breastfeeding for a longer period of time, because the longer you breastfeed, the more positive the impact on your reduction in breast cancer risk. And pretty much everybody said they did not think that would be very compelling, that it wouldn't have mattered for them, and they didn't believe that of all of the arguments that are positive of why a woman should breastfeed, that it was almost focused all on the benefits to the baby, and that that benefit in particular to the mom was not something that was going to resonate unless you were within a population where you knew breast cancer risk was high in your family. So unless you had the personal connection and you were maybe already very aware of your own breast cancer risk and heard about this as a way to hopefully reduce that risk, then you might be motivated by it, but they didn't feel that generally speaking, it would be a very motivational message. So we can, certainly make sure that, doctors, talk about it and, mention that link, that lactation consultants mention that link, that any of the prenatal classes mention that link. But there was definitely not any consensus in our study that it would have any impact on breastfeeding.
Since you mentioned awareness campaigns, there was a question earlier in the chat. What type of awareness campaigns could help employers better understand their legal obligations? Dr. Shankata did respond to that, but I was wondering if there was anything that you wanted to add.
I didn't see her response. I'm sorry, I haven't been able to look at the chat, so I'm not sure what she already shared. That is
maybe Riti can turn her camera on. I put her on the spot because the pump the Pump Act, I believe, Riti.
I want to make sure no one missed it because there's been a lot going on in the chat.
Yeah.
Can you hear me? Sorry
Yes,
about
yes.
that. Hi, yeah, I just wanted to add that sorry, I'm having trouble here. Okay. Yeah, in 2022, there was the federal US Pump Act, and it kind of expanding workplace rights. And I think with that, they've tried, I think Department of Labor has made a lot of different plans in terms of improving awareness around workplace, not only for the employer side, but the employee side. So there's actually a lot of wonderful resources that I put a link there to that include webinars, but then also like flyers that I think employers could place at the work site. But I think so it's definitely both ends, right? You've got to increase awareness on the employer side as well as the for the employees. So I hope that sort of these efforts kind of are a good example of how policy change can happen with everyone sort of all at hands on deck.
Thank
Thank
you.
you. I appreciate that. And I did drop the link in the chat to what Dr. Shinkata shared earlier. So we've got two last questions. If anybody else has any questions, please go ahead and add them to the Q&A. Was there a question asked about family history of breast cancer to their education?
No, we did not ask about that in the study. We were only asking about breastfeeding experiences and their knowledge of the link between breastfeeding and breast cancer.
And then this is a comment/question. Thank you for taking a deeper dive through these focus groups and conversations with people who are personally impacted. I missed the first few minutes of the presentation. Will there be additional studies looking at some of the other racial and ethnic groups or marginalized communities?
That is a great idea, and something that should be suggested to the California Breast Cancer Research Program as the initial funder for this. Because we even in this study, one of the follow-ons that we would recommend them do is looking at disaggregating the Asian community, because we talked to women who identified with different Asian subgroups and their experiences, particularly with the family influence on them, and what they knew about from their aunts and their mothers and their grandmothers' experiences were fairly significantly different between some of the different subgroups. And so a deeper dive into those in particular would definitely be warranted. But yes, I hope that they continue this work and do look at some of the other, because California has a lot of diversity, and we by no means we're trying to say that any of these groups we're going to have it any worse than any other group. Obviously, when we hear a lot of these barriers, the majority of them are things that all women, regardless of your race and ethnicity, are going to end up encountering. But so the good news is that there's also a potential for big impact if some of these changes can be enacted.
And we are going to give them feedback. And we can also suggest, in addition to race and ethnicity, as Tyler had put on chat, we focused on women. That was part of the contract, but looking at gender expansive groups, I think, is missing in insights. And so that's something that we can share with the funder. So thank you.
Absolutely. Thank you so much for responding to that question and as part of the first question. One last question. Did anyone have the ability to do lactation follow-up appointments by telehealth?
So, no. Some of the women did have pre-delivery conversations in virtual space, because some of the women in our study did give birth during the pandemic, when hospitals were really trying to minimize the number of people, and were looking for ways to move anything they could to a virtual space. And so some women talked about that but the lactation visits that were done after birth by and large also included, weighing the baby and things that needed to be done in person. And in particular, if a woman was having challenges, the few that reported that really talked about the need for someone to help them in a very hands-on way, if there was something with positioning or something else physical that helped improve whatever challenge it was that they were encountering, that the in-person was really necessary in their view. So no one took a telehealth afterwards. All of the visits that happened after delivery were in person among the women in our study.
And a follow-up from the person who asked the question, they said, and I asked because I was able to do this postpartum with UCLA and it was so convenient.
Oh, well, I'm glad that it worked for you. It just wasn't, nobody else reported that experience, but if it's out there and that works for women, and this is a way to help give more women access, it is something that should certainly be on the table.
So those are all the questions that we have. I just want to remind you that our next webinar will be a week from today, and it will be Grow and Hide, the History of America's Healthcare State, featuring Colleen Brogan in conversation with Center Senior Fellow and Luskin School of Public Affairs Professor Mark Peterson. Same time, same virtual place. I'm going to drop the link in the chat one last time in case you're interested. And once again, thank you for attending today's webinar. Have a great day.
Thank you.